Welcome everybody to today's webinar on operationalizing care management for financial success, sponsored by ChronicCareIQ. We're going to give attendees a couple more minutes to join the webinar and we'll get started in just 1 or 2 minutes. Okay, I think we have the majority joined us now. So I think we'll go ahead and get started. Thanks everybody again for joining us. I am Claudia Urbano, Director of Industry Partnerships for MedAxiom. And we are going to be speaking today on operationalizing care management for financial success. Before we get started, I'd like to start with some quick housekeeping notes. So if you are, what you see here on this slide is a screenshot of your control panel that you should see on the right-hand side of your screen. You can open or minimize that control panel by clicking on the orange arrow button there at the top. And you can see towards the top where you can connect to audio either by your computer or by phone call. And towards the bottom, you can see the questions pane where you can pose questions to our panelists. We'll hold all our questions until the end of the discussion, all the audience questions until the end of the discussion, and we'll try to get to them all before we conclude the webinar today. If you have any technical problems, you can also use that questions pane to send us a note and our team will help solve the issue. And lastly, this will be a panel discussion and no slides will be shown today, so you won't find a document in the handouts pane at this time. Okay, so let's go ahead and move to the next slide. Yep, there we go. So I'd like to introduce our panel now. We'll be speaking today with Jenna Baxter, COO of Chesapeake and Washington Heart Care, Andrew Metzler, Administrator of Heart South, and Larry Sobel, CEO of Heart and Vascular Institute of Wisconsin. We'll be hearing about their experiences in providing care management services directly to patients with a focus on the clinical and financial benefits while gaining insight into operational success and physician and patient motivations for participation. Larry, Jenna, Andrew, welcome and thank you for joining us today.
Glad to be here.
Great.
Likewise.
All right. We'll jump right in and I'll shoot the first question to Larry. Larry, what made your group consider deploying a care management program?
Well, in our case, we were looking for a partner who could help us do a number of things, but mostly to stay connected to our patients in between office visits. And after talking to a lot of companies, making a lot of reference phone calls, it really became apparent, at least to our practice, that we did not want a third party talking to our patients. We felt that that would be very confusing to our patients, and had a hard time imagining patients asking someone on the phone a question about their care and then realizing that that person doesn't work for the practice. And so it really became important to us to manage chronic care management ourselves and to find a vendor partner that could do that in a way that was technologically savvy and very efficient, but mostly to really benefit our patients in terms of staying connected with us and helping them avoid unnecessary hospitalizations and ER visits.
That's great. Having that connection is so important for patients and for providers as well. Andrew, Jenna, anything to add there?
Yeah, I think the other big thing is it's capturing revenue for work we were already doing, right? We're already doing, and I think our practice and a lot of other practices were doing a lot of these functions, maybe in an informal and less organized way, but by putting some structure to it and implementing a technology solution, we can gain revenue for work that we're already doing. So I think that makes, that was a big drive for our practice as well.
Fairly similar with my group. The only difference was they initially thought that we could do it on our own without software, and that the group could manage it, and that quickly became unrealistic.
So I'm hearing that the need was there, or at least the understanding of the need to be more connected to patients was there, and it was a matter of how we were deploying it, correct?
Correct.
Great. Yeah, there can be many preconceived notions on chronic care management and remote patient monitoring and the time and effort it takes to maintain these programs. Did you encounter any surprises? How did care management differ from your expectations? Jenna, I'll start with you.
My doctors first pushed back and were hesitant. They were interested, obviously, in the new revenue stream, but thought it would be an unrealistic time drag on their time in addition to the regular office visit, thinking that the patients would have voluminous questions and it would just slow them down, and that the staffing needs were going to be extraordinary. And through project planning and help with Matt's group, we were able to put it together pretty seamlessly, and the doctors were relieved to know that it doesn't take pretty much any extra time for them.
Great. And just for clarification, by Matt's group, you're referring to ChronicCareIQ.
Sorry.
Matt,
That's ChronicCare.
Yes, no, it's all good. Yeah. Andrew, how about you? Any surprises?
Yeah, I think, well, I think we had a good grip on what this would be. I think there's, we had other practices that we visited and kind of modeled our program off. Our program is relatively new, started in the last 6 months or so, and we spent a lot of time, learning from other practices who were doing it well, and there's some good examples of that out there. So we kind of knew what we were getting into from an operational standpoint. I think the big surprise for us was kind of maybe some of the more intangible benefits with patient engagement and patient connectivity. I think we knew what it was supposed to do from a clinical standpoint and with all the clinical goals we wanted to achieve, but I think we didn't realize how much of a patient satisfier it would be. We kind of underestimated that. So I think that was the one big way that differed from our expectations, is that patients just love being connected. They love the extra attention. They love that engagement that they weren't getting otherwise, or weren't getting enough of, I guess. So that was one thing we kind of didn't expect to see. So that was a big one for us.
That's great to hear. Larry, how about you? Anything that differed from your expectations?
Well, I would echo what everyone else has said, but I'll mention one thing that was really eye-opening for us was the initial analysis based on our phone system, how many minutes we were spending with Medicare patients on phone calls per month. It was, we thought it was a lot, but, when you get that tally of the literally hundreds of hours, and some patients having, multiple hours of calls into your practice each month, that was really mind-blowing for us, and it made us realize, as Andrew said, that we're doing this work already, and Medicare's come up with a methodology where they'd like to reimburse us for that, and so certainly one of the benefits is to take advantage of that. But it was really eye-opening how much time we spent with patients on the phone.
That's great. How about adoption? Adoption is always different for different organizations. How did you engage your patients and enroll them into the program? What's worked for you? Andrew, let's start with you. What's worked for you on getting that patient adoption?
Yeah, I think that the first and foremost, and probably pretty obvious, is a good physician champion. Having somebody who's kind of willing to help develop the program and kind of build that confidence. with the physician peers, kind of physician to physician engagement as opposed to administration to physician or vendor physician, physician to physician engagement is always strongest, and having a good physician champion is important for that reason. Other things, kind of basic, email blasts, those types of things. I think what we've done that we've found to be really successful is taking some of those win stories and that really high level of patient satisfaction and translating that into videos, patient testimonial videos, patient videos explaining kind of how it works, why they benefited from it, and stuff like that. And so that in addition to physicians championing it in the clinic, that you have patients, kind of through all of our advertising means able to share that. So that was one thing that we've gotten a lot of positive feedback on, and a lot of attention was just patients on camera telling their story and why this is helpful to them. So that's one thing I'd encourage.
Great. Yeah, I've seen those videos on your website. They're great. Larry, how about you? Anything that you'd like to share on how you engaged your patients and got them enrolled and adopt the program?
Yes, I think one thing that we try and emphasize to patients is that this is a program that we're working together with Medicare to help them avoid unnecessary ER visits or worse, unnecessary admissions or readmissions. And so we really try and emphasize the clinical benefit to the patient, aside from being able to get information from them and stay connected and monitoring their health in between their office visits.
Mm-hmm. Jenna?
We put some signs up in all of our waiting rooms, and then we had a nurse review appointment schedules a couple days in advance, and we developed a half-page flyer that bulleted out that Medicare was providing this, and we were going to keep you out of the hospital and keep you better connected with your physician and APP staff. And so they got that at check-in. So as they sat in the waiting room, they read that. Then it would be handed off to the medical assistant or the nurse in the exam room, and they could answer the questions. So by the time the doctor got there and wanted to talk about it, if the family was there, they were already engaged. They were ready to go.
Great. Going into that a little bit, Jenna, you were just touching on staff. So I'm curious, how many additional staff members did it take to effectively manage the program? And I'm going to shoot that one to Jenna, since you were already kind of touching on the subject.
I struggled with this because it had to be an RN, and I didn't have an RN that had the additional time. And then with some of the implementation and talking to some other practices, we realized that an RN could lead the project, but we could have experienced medical assistants. And it really became like one medical assistant who needed some oversight with some help from, a doctor when the patient pushed the button that they wanted to call, or they were having symptoms, that kind of thing. And then they would go to the nurse or the project manager. But originally we thought this was going to be 2+ FTEs, and we're managing it with one, with over 1,000 patients.
Nice. Wonderful. Larry, how about you? What's your staff look like?
We started with a nurse who volunteered to be the internal champion for it, and she really did a great job of educating the physicians, educating the staff, and so for the first 4 months we pulled her out of her pod and she got everything set up, and now we're transitioning that to actually a non-clinical person who will monitor the dashboard and then work with the nurses and MAs in our 4 pods to keep them informed through EHR messaging, when an issue needs to be addressed. And so, we're I'd say 3/4 of the way towards 1,000 participants. And at this point, we're anticipating that one person full-time will be plenty to manage the program from here forward.
So it sounds like a similar ratio there. Andrew, are you experiencing something similar or different?
Yeah, so our program, as I mentioned earlier, is a lot newer. We're only about 6 months in, so we don't have quite that volume. I think we're in the 300s range in terms of total volume, but kind of as a launch and implementation, process, we're planning on having one, full-time LPN when it's all settled, and then we kind of have a nurse manager and a project manager kind of helping launch and navigate, kind of a new service to our business. So kind of having some project management support to that, and that helps with things like marketing materials and training and those type of things. But I think similar to the others, it's not just kind of one. You have that one internal champion, but I think you really have to stress the importance of all of the clinic staff being familiar with the program, being able to talk about that program, because those are the frontline people who are helping engage with patients, answering questions, encouraging enrollment, and stuff like that. So you kind of have that one nurse champion to kind of lead and manage the program. But for my practice anyway, all of our clinical staff are kind of aware of it and thinking about it, and because they have to work with the patients when they see them in clinic. So it's very much a team effort. But as far as incremental staff, just the one LPN at this time.
Great. This is such valuable information, and I think, Larry, you touched on this a little bit earlier. I was talking to the ChronicCareIQ team the other day, and I learned of some impressive metrics, millions of data sets per month. And this actually, Andrew, it speaks to also, well, all of you, the cleanliness of the data, the prioritization of the data. Sounds like it's all very manageable with one person to kind of follow that. So millions of data sets per month from CCIQ, around 29% reduction of 30-day readmissions, as well as all-cause cardiac hospitalizations, 91% of highly satisfied patients, 167,000 alerts that have avoided readmissions. I mean, all very impressive metrics here. I'm curious to your experience with this. I'll start with Larry this time. Any feedback from your clinical staff or patients? These numbers are so impressive. I wonder how both the staff and the patients are, how it looks on their end.
I think we're very impressed with the clinical algorithms that go into the dashboard. And so to be able to look at our enrollment population every day in terms of who's in red, yellow, or green status, and obviously focus on those patients in red status, but not only that, to really understand the rationale behind what puts somebody in red, yellow, or green status, particularly red status. And so we have lots of examples of either one, we're watching people who transition from yellow to red, and then we're able to reach out to them proactively. But also the technology allows patients to notify us in terms of exacerbation of symptoms, or as they're self-reporting different metrics, say blood pressure or weight, being able to notify us that, my blood pressure is rising, or we can see that trend, or my daily heart rate when they take it. And so I think we're just very impressed with the clinical efficacy of the whole CCIQ program and product.
Great. And then from your patients, I think you had told me a story, Larry, about a retired nurse who was kind of skeptical of the program, and then as a patient was impressed with it.
Yeah, it was actually her husband who's enrolled in the program, and so it was an interesting. This was very early on. She was one of our early enrollees, and I think she was skeptical that anybody would pay attention to the data, and so we saw her husband go from yellow to red, and we reached out to her husband. She happened to answer the phone, and her reaction was, wow, you really are paying attention to this, and really became a huge fan. In fact, she switched. We default to weekly emails or text for everyone who begins in the program, and she requested to go to daily because she felt that it would be that much more helpful. Not that they necessarily submit data every day, but they wanted that option. And so she's really become quite an advocate and has talked a number of her friends who are patients of ours into also joining the program.
That's great. How about you, Jenna? Any feedback from your staff, clinical staff, and patients you'd like to share?
The staff, the support staff really have championed it because they felt like it was taking phone calls off of their workload. We were being proactive to reach out to the people, or as Larry said, the patient can push, give us a call, and you can head some stuff off at the pass. The families love this. If my parents were alive, they'd be signed up because we're all busy. We all work. You're barely trying to keep in touch, make sure everybody's good, they got their medicine and this kind of stuff. It's an extra set of eyes on your loved one. I mean, it is.
I couldn't agree more. How about you, Andrew? Any stories or feedback you'd like to share on that you've learned from your clinical staff or your patients?
Yeah, we've absolutely collected a lot of positive feedback, particularly from our patients. Like I said earlier, that's kind of been an overwhelming kind of response is the patient satisfaction. And they're going and telling their friends and family about it, and they're also telling their physicians about it. So that's, I think, one of the big things that we're seeing now is patients who've been in the program for a while go back and tell their physician, hey, this really helped me because X, Y, and Z, that becomes a self-fulfilling prophecy in that feedback loop with the patients giving good feedback to their physicians, and physicians ordering it for more patients and becoming more engaged in the program as well. But I think it's important to highlight those wins. With the patients, you got to highlight those wins with the staff who are putting in the time, right? So they believe in it, and with the physicians as well. But I think, but it doesn't have to be kind of the big clinical, like, episodic wins. Like, we have some of those, and those tell really cool stories about, we saved this person, but even other wins, like, that otherwise healthy, 75-year-old grandmother who just wants to be a little bit more engaged between her yearly follow-ups. She's pleased, and that's a win too. So you kind of have those kind of episodic wins, but the kind of smaller, more everyday stuff that is still hugely important. And the patients just can't, it's almost like like Larry said earlier, they want more than we were prepared to necessarily offer them. So you can't beat that. But
great. So we're hearing that both physicians and patients find true value in these programs, which is vitally important to the quality of care. What about the financial impact to your organizations? Have you found this to be an economically sound addition to your programs? Any other benefits you'd like to share? Larry, why don't we start with you on this one?
Well, we hit and began to exceed our break-even point within the first 4 months. And so while we don't emphasize this so much as a financial benefit, obviously we enjoy the financial benefit, but I think we were pleasantly surprised that it does really offer a strong reimbursement for work you're already doing, and is a strong return on investment. And so we've been very pleased with that.
I mean, just a few months, that sounds like a quick turn there to be able to reach that ROI. Jenna, how about you? Anything you'd like to share?
We also found that the APPs in particular, because I think a lot of the patient phone calls at the end of the day trickle down to them to make the phone calls. And in our practice, we have a productivity bonus. And so all this work, they were spending an hour, they were on the phone until 6:30, suddenly became that it was a huge satisfier for that group, because they were being paid now for things that they were doing, not just office visits. And the other thing that we experienced was I had one of the original nurses that helped us set this up. she was in a BSN program, and she had to pick a project, if you will, to complete her BSN, and she was able to demonstrate that in a 9-month period of our congestive heart failure patients, we were able to decrease hospitalizations 11% within that subset of the chronic care. And that was huge for us, all the readmissions.
I think that's huge for any program, 11% in 9 months. Andrew, how about you? Anything you'd like to share on the financial impact?
Yeah, tagging off the last thing that Jenna said, we have a agreement with the hospital where we're measured and paid off quality metrics with one of the hospitals that we work with, and readmissions are one of the key metrics in that agreement. So anything that we can do to reduce readmissions is just immediate, almost immediate financial gain there for us as well. In addition to kind of the self-sustaining internal program, of course. But I think bigger than those two things is kind of the branding and the brand awareness and that this level of patient engagement provides. When you're able to, the handhold might be may not be the nicest way of saying it, but when you're able to make patients feel so engaged and taken care of and so consumed by what we have to offer them, they become true believers in not only the care management program, but any Hearts Health or my practice as a brand, as an identity, and keeps them loyal, keeps them engaged, and helps get them when necessary, get them in the door or keep them out of the door, as the case may be, what have you. So I think that level of engagement just speaks volumes to, again, our brand identity, as well as, again, the word of mouth engagement that this kind of satisfaction provides. So I can't speak enough about that. In addition to, like I said, the financial sustainability, I think that's again a bonus that we weren't prepared for, but very glad to have.
Yeah, it's great to hear all these, like 11% in 9 months, and reaching break even in 4 or 5 months, and having a different perspective with the patient engagement. All of that is so important. To have these engaged patients means a healthier population, which means reduction of costs of the system. So this is all just a great for the entire ecosystem. So I see we have a lot of questions from the audience coming in, so I'm gonna go ahead and pose one last question, kind of open-ended to all of you. I'll start with Larry on lessons learned. Anything you'd like to share with us on something you do differently or would encourage our audience to do the same, or any future plans?
Well, a couple of things. One, as you might expect, providers maybe had each provider had a different perspective on their role in this process. And we've really emphasized, in our EHR pops up a message to a provider every time that they're seeing a patient that is a candidate for chronic care management, and indicates whether they're enrolled or not enrolled. And so the first lesson we learned was keep it simple for the providers. And so we scripted and help them really look at this as you're really prescribing this to patients. And so we offer a little trifold brochure, which they, hold it up, they could pick one of 11 different disease categories. And the message we say to our providers is, you only need to spend 30 seconds. You're telling a patient, I'm prescribing chronic care management to you because you've got different chronic conditions. We want to stay in touch with you clinically. We want to keep you out of the hospital in the emergency room. And they simply check off the appropriate condition, give the patient the trifold brochure, and say, after I leave the room, my staff will come in and explain more about it and enroll you before you leave the building today. So that was our first message. And the other one was, I think we really learned that, the staff are critical as well in terms of advocating for the program. And so, doing a lot of training with nurses and MAs, and particularly we enrolled all of our clinical staff as test patients so they could experience it for themselves and see what the questions looked like. And I think it gave, each nurse in MA a greater perspective in terms of this is how it really works. This is what the patient's going to see, and made it much easier for them to explain it and advocate for it and convince patients of its value.
Very smart. How about you, Jenna? Lessons learned, anything you'd like to share? What'd you do different?
I think probably more the same, except for, the physician champion is key, and you've got to get everybody together so everybody's on the same page. And don't underestimate the need. In the beginning, everybody's enrolling everybody. And then all of a sudden it waxes and wanes, and you're seeing that, I'd have the nurse who's over, it's like, hey, you only have 6 enrollments this week. So we created incentives. Don't underestimate the competitiveness of your group, your doctors and your clinical staff. We put out a bonus for the clinical staff for every 20 that they could get their doctor or APP to enroll. They got a $100 bonus, and then we plastered it on the wall as a graph as to how many new patients and how many chronic patients. And it was interesting as to, even from the physician level, how that got people's attention.
Yes, I think we do have a competitive group here in healthcare. I think that works well. Andrew, any insights from you on anything you do different or lessons learned?
Yeah, the one thing that we changed with our chronic care management program about 3 months ago, or a few months into our 6 months so far, is we dropped the word chronic. We found that, patients, I have a very, rural patient population with relatively low health literacy, and the word chronic was scary to some of our patients. They, were asking questions like, do I need hospice? Am I going to die? Those type of questions. And we kind of didn't want that kind of negativity or negative connotations associated with this program. So we kind of relaunched and rebranded it a couple of months ago to something that we now call Heart South Connections, which is, it's our care management, it's our chronic care management program. It's the same thing with a different name, and makes maybe maybe a little bit more positivity to it, rather than like, keep, we want to keep you out of the hospital and that's the goal, but we don't want to also make you feel like you are going to die. We really truly had patients think, does this mean I need hospice, or questions like that we certainly didn't mean to communicate with that. So that was the one big learning. And then kind of as we did that kind of rebrand of this program, we kind of did a hard, like, actual launch rather than just kind of a slow implementation. We kind of made a big push to it, and I think Jenna kind of also hit on that earlier. It's everybody, everybody's helping out at the beginning, and we had to make sure we did that as well, rather than kind of a more softer, slower launch. So that was kind of the one learning, or one thing we've changed since then.
Great. That's very interesting. Dropping the word chronic so we can address, any misconceptions of it. That's really interesting to me. Great. I'm going to jump into some audience questions here, and let me get those pulled up. How did the panel deal with the patients being confused? Meaning, their normal doctor is Dr. Smith, so why is Dr. Jones or APP Bob or RN Susie calling them and then being hesitant to have the call open up and share necessary information? Interesting. Jenna, why don't you start with this one? If you'd like to answer the question, just raise your hand for me.
No, that's fine. I mean, I've never had a patient be upset to get a call from a doctor's office. They really don't care who they're talking to. I mean, and most of these people, when you look at your monthly reports, they have no problem talking. 20 minutes, poof, it's more like 60, 82 minutes. I mean, they want somebody who's willing to listen, and my staff, and I'm sure Andrew and Larry's, I mean, there's scripts, and you say, I'm calling from Dr. Boopity Boop's office. He asked me to call you, and he thought this would be good for you, and whatever. Or if they push the button, they're just excited to not have to wait on hold or get a call back. They're excited to talk to somebody. That hasn't been a problem at all for us.
Go ahead, Andrew.
The one thing that we did because I had the exact same concern starting out. So when we kind of made our one full-time position, we kind of shuffled some things around. So that lead person that we have is someone who's been at my practice for 20 years and already has been talking to my patients forever anyway. So we kind of used a known. I'm in Alabama. This woman's from the upper Midwest. She has a very distinctive accent. Everyone knows who they're talking to when they talk to her.
Hey, I resemble that.
Yeah. So she's my point person is already a known entity and a known nurse and already has a strong relationship with a lot of patients. So we kind of had that same thought, and we decided to use kind of one of our nurses that was already kind of known to most of our patients for that reason.
Great. Larry,
I
anything
was going to add I was going to say because we work in pods, it may be, Dr. A's specific nurse that's calling you, and patients are probably already familiar with that individual. But what we try and train our staff is no matter who you're calling and whatever physician or patient you're calling about, you should introduce yourself as, I'm a nurse with heart and vascular working with Dr. So-and-so, and the patient doesn't really need to know the details of where you fit in organizationally. And as Jenna said, patients are just so appreciative that you're reaching out to them, particularly when you could say, I'm calling you because you left or you messaged us through ChronicCareIQ and asked for a phone call, or I'm calling you because we saw we recently did a medication change and it doesn't look like your blood pressure is lowering to the degree we'd like it to. So we'd like to talk with you more about that and maybe try a new med adjustment. So I think patients are just thrilled to have the contact.
Yeah, I would agree. I'm going to shoot this next question back to you, Jenna, starting with you, because I think it's direct to the figure you gave earlier. If one nurse manages 1,000 patients, who completes the care plans? How many MAs under the RN supervision?
So I guess we won't say we cheated, but we created the clicks in the EMR. And I worked with 2 physicians to come up with first the admission, because Medicare requires that you have an order to admit. So that was 5 clicks. You picked your protocol and what the goals were, and they were fairly generic goals. And we've had some reviewed and have not had a problem. We assign out on a rotating basis for people to go through when the care plans come up, and to make sure that they're up to date, to see if there's any changes, and the APPs will help them if they need assistance. So that isn't one person, that's too many. And the other thing is it was overwhelming to me at first that suddenly you have 1,000, you have 1,200 people. But oddly, all of those people don't use 20 minutes of your time. So they're down low, and then you get the big talkers and your really sick people up at the top. So it's an interesting dynamic, and it's such an overwhelming number, but it's not realistic that you're doing 20 minutes with 1,000 people.
Right, because they're all prioritized in order of need of care.
Correct.
Right. Anything you'd like to add there, Andrew or Larry, on completing the care plans and any additional staff that might be needed for that?
I was going to add that it's, go ahead, Andrew.
We do it much the same way as Jenna's group, but we just have much smaller volumes, so it's a lot easier for us at this point. Hopefully one day we're at that level, but our volume is a lot smaller. So, but otherwise it's modeled very similarly.
Yeah, I was going to say, because ChronicCareIQ interfaces with our phone system, it automatically counts the minutes regardless of who in the practice is interacting with that patient. And so I think that takes a huge burden off of the staff, because they're doing what they normally would do. And they're only proactively calling a patient if they've turned from, say, yellow to red, or they've requested a phone call. Regarding care plans, we're really in the process of transitioning that from the initial nurse who was doing it to all of our nurses being capable of doing a care plan. And as Jenna said, keep it simple, keep it templated, and it's just a routine part of the enrollment process.
Great. Do other insurers other than Medicare reimburse for this? Andrew, I'll start with you.
Yeah, a wide variety do. Obviously varies by state, but we're seeing that a fair amount of them here do as well. Copays are very wildly per carrier, though, some such that it's not necessarily feasible for some payers, but absolutely, and exactly which ones will vary per state. But here in Alabama, we're seeing that multiple do, just with a wide range in copay.
Same for you, Larry.
We haven't ventured into commercial payers yet. We're about 73% Medicare, so we have plenty of work to do to enroll that population. But I am working with some local employers to possibly do an employer-sponsored chronic care program, as they do, say, health risk assessments on their employees, and they identify hypertension or diabetes or whatever, potential AFib issues. I've got some employers who are potentially interested in paying for chronic care management on a fixed monthly fee for their employees or covered dependents who would then participate in our program. Haven't fully gotten a single employer yet, but we're having a conversation, and I think there's strong interest, particularly from self-funded employers.
Right, that makes a lot of sense. A lot of opportunity there. Jenna, anything you'd like to add to that?
The only other thing would be that we also kind of dipped our toe into remote monitoring, which is also part of the software package. And of all payers, Anthem to come out and pay for remote monitoring, we jumped on that wagon in the middle of the summer. So that's turning out good. And especially the other the other item that we're monitoring, remote monitoring, is in our EP side, and I'll get it wrong again, the little one that looks like a Band-Aid. Is it cardio?
Cardio.
Yes, and they are my doctor set it up so these patients were emailing them every day and nobody was getting paid for it, so we had to quickly take control of that. So remote monitoring is helping with that, because these people send it all the time. It's not that, oh, can I get 16 in a month? You get 16 in a week, so it's not an issue.
Great. I have two materials and protocols. We'll be in touch with materials and protocols for those that requested it. The program is ChronicCareIQ, and we will be in touch with some follow-up information via email after the webinar for those that are asking questions on the program itself. One more question there's quite a few. Are you all writing off patient copays with commercial insurances or considering them patient responsibility and billing patients? This might be something I'll throw to Larry first.
We will do an adjustment for patient copays. As Andrew said, we're finding, particularly with some Medicare Advantage plans, that because they're not familiar with chronic care management, they're charging a copay for a monthly chronic care management fee similar to an office visit, so it might be $50. And so if the patient calls our billing office, we will make an adjustment down to $10. So we try, and if patients request it, we try and limit their out-of-pocket to $10 per month.
Andrew, how about you? Is it kind of?
Yeah, we're not adjusting at this time, no. Okay. That hasn't been just too much of an issue. We're trying to make sure everyone's informed of what the cost is going to be, and if they're not willing to pay it, then we're not enrolling them at this point. But truthfully, it's not something I've considered, so that may be something potential option as well.
Jenna?
I hate to answer this because it's probably being all recorded, but yes, we do it.
You don't have to.
So I flipped this out. But $8 to a Medicare patient, oh my God. After a while, it's not worth the argument. So there is a fair amount that we do adjust off.
Okay. Great. And what does the program cost? This might be a a longer answer, but let's see how much we can get kind of squeezed in here. I do have a couple more questions. So general answer, Andrew, what does the program cost for you, the ChronicCareIQ program?
ChronicCareIQ is able to kind of start us out at a lower rate to kind of help get us up and going to kind of, as we kind of build to that break-even point, to make that an easier to achieve metric. I have it in my head that it was in the realm of a couple $1,000s, and then kind of a higher rate per month. I'm sorry, after that, but yeah, it kind of fixed, understandable budgetable cost plus the cost of labor that for the software program. Cost of labor, the one incremental FTE we discussed, and then I think just very few other miscellaneous costs, maybe having to do with the integration or stuff like that. So all in all, as far as it's not a significant budget outlay or investment, and again makes ROI relatively attainable for that reason.
Jenna, how about you?
It is, the cost of the one project person in addition to the software, which obviously, it's up to Matt to discuss, but from a per provider, not an APP cost. And as Larry also alluded to, within 3 months, we were over break even. So it pays for itself.
Right. Larry, anything you'd like to add, or should I jump to the next question here?
Well, again, it's a per provider fixed cost for the most part, and from my point of view, a great value because it's certainly not an overwhelming amount. And as we said, you really break past that break-even point relatively quickly if you put some energy and focus into this.
Yeah, I think among those metrics that CCI, the ChronicCareIQ team, was sharing with me earlier was the top quartile billable average is $83.33 per patient per month. So add that all up and you get the experience that you guys are experiencing yourselves.
Yeah, I think we learned, don't just think that it'll be $42.90 per month because you're doing 40 minutes or 60 minutes or more with a number of these patients. Plus the initial fee, is an extra charge for the care plan. So you get an extra bump at the start for each enrollee.
Okay, great, thank you. What about your referral sources? Are you worried about upsetting your referral sources by offering chronic care management to their patients? Or your referring physicians feeling alienated? Andrew, I'll start with you, although I see you shaking your head, so it looks like maybe the answer to that is no.
Yeah, honestly, our main referrals are obviously our primary cares, and we have such a primary care shortage in my area that they're glad for they're glad for it. No one else is doing it. We're the only people in our market doing it, and so it's not like you have to worry about stepping on their toes from they want to bill for that service for that patient, but they're thrilled because we're so chronically short of primary care providers, and none of them are doing CCM. So we haven't run into a single issue with that so far.
Great. Jenna?
We had 2 primary cares in our area that were pretty big referring docs to us, and we made the decision that if the patient had 2, that we would defer to them. And so that went on for about 3 months, and then those primary cares folded their program because they were trying to do it manually. So it didn't work.
Okay, and Larry?
We talked to one of our larger referral groups, which is a large independent primary care group, and explained what we're doing. And quite frankly, they said they were not interested in pursuing this, that, just they didn't feel it was worth the effort. They had a different payer mix than we did, maybe not nearly as strong from a Medicare point of view. And so it hasn't been an issue, and we're the only group in our area that's doing this.
Great. Now, what about connected devices? Are any of you planning to start using connected devices? I'll go back to you, Larry, on this one.
Well, actually, CCIQ just sent me a cellularly connected scale and blood pressure cuff that we're anxious to test, and we're very excited because we would like to issue devices, remote devices for patients that automatically load data into the clinical algorithm and the dashboard, and so that's the direction we're going to head. And CCIQ has different vendors that they work with, but we've kind of used them as a guide in terms of which devices we should trial.
Great. Jenna, any experience with connected devices, or are you planning on using them in the future?
Yeah, we have 2 patients that are trialing the blood pressure cuff that I'm sure Larry just got to see how it works before we would start using that on a bigger scale.
Great, and that just got started?
Correct.
Great. Andrew, how about you? Anything to add?
Not yet. Okay. That's in our roadmap for the future, you know, but kind of wanted to, again, continue to grow this program first before we add it to it. Eventually, but not yet.
Right. And how about, this is always a popular question with does it require integration with other technology? I'm sure. And how does it integrate? What was your experience integrating into the EHR for that? So I'll start again with Larry.
Well, our integration with our EHR is mainly that we're using the EHR messaging system, so that if, say, the coordinator views something on the dashboard and needs a nurse or MA to follow up with the patient, they simply use the EHR to message them and indicate that, you know, this patient requested a call back. And so that's really, at this point, our only integration with the EHR. As I said, the main benefit so far for us has been integration with our phone system.
Okay, the phone system is picking it up.
For counting minutes, yes.
Great. Jenna, how about integration?
Pretty much the same as Larry. We didn't do any more interface other than the messaging.
Okay. And Andrew, same with you?
Also the same, except to add that it was so easy that I didn't even have to think about it. Like I just said, we're going to do it, and then it happens. I'm going to answer for it, because it just kind of happened.
Well, that's great to hear. And it looks like we have one more question. What was the implementation time frame? So how long did it take you to implement? And then we'll be very close to time. We're about 7 minutes away from time. Let's start with Jenna.
I would say probably between 2 weeks and 30 days for it to really be smooth. I mean, the difference here is that none of this is a panic. At first, we thought, you know, we had all the protocols written out with ChronicCare's help, and so staffing was the big challenge. And then people would task that, you know, Dr. Jones admitted these 6 people, and that nurse or that MA or whoever it is calling those people to do it. If they're in the office, they'll go over and introduce themselves. But it's not the panic of somebody that's in your office that needs something right then, because we're selling them on a remote, you know, device to keep in touch with us. So I think it comes across in the beginning, you're like, how are we going to get this all done, because we have so many patients? But it becomes second nature, and other people just help. When you have a ton of admissions to it initially, you assign more bodies to it to get people enrolled, but then it just kind of has a good flow about it. It's not like everything else that we run around for.
Kind of going back to what Andrew was saying earlier with the self-fulfilling prophecy. So it sounds like it's pretty easy or quick, not a long implementation period, but then it just keeps growing on its own organically. Andrew, I'll let you follow up on that one, and then we'll go to Larry.
I'd say as far as total implementation, I think we spent maybe 1 to 2 months kind of evaluating all of our options as far as who to partner with and what this would look like in operation, just kind of 1 to 2 months planning. And then we started, like I said, about 6 months ago or so. And I think it's been pretty linear growth since then. And like I said, particularly after we kind of did a rebrand and relaunch earlier about in the summer, it's kind of really taken off from there. So I would still say, just because of how new our program is, we're still in kind of an implementation phase, but we had less than 2 months to have a functioning, well-running program. We think just kind of, driving continued growth and finding new strategies, for that. It's been just kind of an evolving thing, but I think we're hopefully on the what I would say tail end of implementation at this time.
Great. Similar with you, Larry?
Yes, it was a fairly quick launch. We launched it in one of our general cardiology pods first as kind of a pilot, but the intention from the beginning was the entire, we'd eventually roll it out through the entire practice. But, we picked the pod that, quite frankly, had the 2 largest patient panels for those physicians in that pod, 2 of the physicians in that pod, and also picked them because they were more likely to be strong advocates. And I'll just remember the one physician walking around in the first week kind of bragging, I enrolled 10 today, you guys will never catch me, kind of thing. And so it's been really a fun competition sometimes between the doctors. And we, like Jenna said, we publish our enrollment data every week, so we show the physicians where they're at and what our progress has been.
That's great. Well, I will check one last time. Yeah, I think we've answered all of the questions. I want to thank you all for your insights. And yes, your wonderful programs. I really, really appreciate all the information. I'm excited about what you're doing, and thank you for joining us, and thank you for having the vision to take this on and improve the care for your patients, and creating those champions inside your organizations to be able to really get this program developed and into growth mode. Thank you also to the audience for joining us. We'll follow up with email with some more information soon. Thank you, Larry, Andrew, and Jenna, for being here with us today.
Thank you, Claudia.
Thank you.
Bye-bye.